This is an international inter-observer and derivation study for the detection of advanced neoplasia in intraductal papillary mucinous neoplasms using confocal laser endomicroscopy. Detection of advanced neoplasia in mucinous pancreatic cystic lesions is challenging. Advanced neoplasia in IPMNs is defined as the presence of high-grade dysplasia or adenocarcinoma. With the current standard of care, including the latest guidelines, nearly 40% of resected IPMNs tend to have low-grade dysplasia. In other words, we can potentially avoid resecting nearly 30 to 40% of pancreatic lesions, which may have low-grade dysplasia. Among the new modalities for diagnosing pancreatic cystic lesions, EUS-guided needle-based confocal laser endomicroscopy is a novel technology. It has been shown to have high accuracy to differentiate mucinous versus non-mucinous pancreatic cystic lesions. In two large studies, including a French multi-center study and a single-center study at The Ohio State University. However, to date, there have been no investigations evaluating assessment of dysplasia in IPMNs using confocal laser endomicroscopy. Thus, we sought to derive endomicroscopy criteria for the detection of advanced neoplasia in IPMNs. Here is the procedure for endomicroscopy. This is a processor used for endomicroscopy which gets the video feed from inside of the cystic lesion. This is a probe which has a diameter of 0.9 millimeters. The probe is preloaded in a needle. This is the EUS scope. The scope is introduced through the stomach into the small intestine. Once the cyst is identified, the needle is introduced into the cyst. So the needle is in the cyst. The probe is advanced beyond the needle tip as here. And once the tip of the probe touches the cyst epithelium, we get a representative video. Here in this example is a IPMN lesion with finger-like projections or papillae. This is a pathognomic feature of IPMNs, and this is how we diagnose these lesions. This study was done in 3 phases. Initially, we derived the criteria internally. Then we tested the criteria in 2 phases among external observers. There was a 2-week washout between the 2 phases. The patients were recruited from a prospective single-center study, the INDEX study at The Ohio State University. There were 26 subjects who were recruited. 9 had low-grade dysplasia, 17 had advanced neoplasia. Among the 17, 12 had high-grade dysplasia and 5 had adenocarcinoma. Here is the description of a papillary structure, which is the key feature of IPMN lesion. These are finger-like projections with the inner vascular core and an outer epithelium. The inner vascular core appears bright because patients receive intravenous fluorescein, which gives a bright color because the fluorescein flows through the blood vessels. Here are various configurations of papillae. They could be longitudinal, or we can see them in transverse sections as in here, or sometimes the papillae are very small as in here with a much thinner epithelium. As you see, the thickness of the papillary structure varies, so also the thickness of the epithelium also varies. Going back one slide, the thickness of the epithelium, this is the thickness of the epithelium of the papillary structure, varies among patients based on degree of dysplasia, so also the darkness of the epithelium also varies. As far as deriving the key criteria, here is the thickness of the papillary epithelium. Here on the left is a low-grade dysplasia, on the right is a high-grade dysplasia. As you see in those with high-grade dysplasia, the epithelium is much thicker, nearly 40 to 50 microns compared to 10 to 30 microns in low-grade changes. This is because of cellular stratification, meaning as the dysplasia progresses, there is increase in the number of cells. Along with that, there is increase in the darkness of the epithelium, as you see here. On this right side, this is a high-grade dysplasia with much darker epithelium. On the left is low-grade dysplasia, much lighter epithelium. This is because along with the cells, the nuclei in the cells also increase, meaning they stratify, and the nuclei appear dark during endomicroscopy. Hence, they impart a very dark color to the epithelium. So there is increase in the thickness and the darkness. Further, we tend to see large, dark, and irregular papillary structures compared to much smoother papillae in low-grade dysplasia as seen in this picture. Sometimes we also see very large cells, which are the cancer cells, and the blood vessel pattern tends to be very intricate due to neovascularization. Here are two videos showing low-grade dysplasia with smaller papillae, thin epithelium, and the vascularity is not as dense as seen here. On the other hand, high-grade dysplasia, you have much larger papillary structures with multiple dark dots which are nuclei. So there is increase in thickness and the darkness. So also in high-grade dysplasia, we get much more intense vascularity compared to the low-grade lesions. Here are two more videos comparing low-grade and high-grade. On the left, we have much less intense vascularity, rope ladder type vascularity, and the papillary structures are much thinner and flatter. Compared to that, in high grade, we have much larger, thicker papillae, thicker and darker epithelium. Here is a panel of pictures comparing the features. We came up with six criteria: epithelial thickness, epithelial transparency, the size of the papillae, the density of the papillae, intricate vascularity, and intracystic cellularity. Subsequently, the external observers reviewed these six criteria, and we performed an inter-observer agreement study. The two top features were thickness of the papillary epithelium and transparency of the papillary epithelium, with an accuracy of 86 and 84% respectively. For thickness of the papillary epithelium, the kappa was 0.61, which is a substantial agreement. For transparency or the darkness of the epithelium, the kappa value was 0.55, which is a fair degree of agreement. So again, looking at all these variables, the epithelial thickness, epithelial transparency were the two top features. So also papillary size also had a fair degree of agreement at kappa value of 0.49. Overall, the sensitivity to diagnose advanced neoplasia was 90%, specificity was 73% with an accuracy of 84%. So the limitations are that this is a single center study. We need more objective interpretation with quantitative measurements, including of epithelial thickness and transparency. In conclusion, EUS endomicroscopy can potentially differentiate IPMNs with advanced neoplasia. Supplementing current pancreatic cystic lesion evaluation with endomicroscopy can hopefully promote more meaningful resections of IPMNs. Future directions, we need multi-center studies with quantitative measurements, including computer-aided diagnosis.